So, Dr. Stuart McClellan is an associate teaching professor in the Faculty of Nursing at the University of Alberta and nurse practitioner in Alberta Health Services, Correctional Healthcare. In addition, he's an adjunct associate professor with the John Doster Health Ethics Center. He is presently interested in understanding and improving subjective experiences of pain amongst people who are incarcerated, applying relational ethics to complex correctional healthcare practice situations, and developing effective therapeutic relationships in distressful environments. Without further ado, I pass it over to you.
Thank you, Michael. And I do work in provincial correctional facilities as a joint appointment. So I do have to acknowledge that building off of the land acknowledgement from Michael, that many of the people who are incarcerated in Canada and Alberta and beyond are disproportionately individuals who are Indigenous to these lands, and we recognize that there's the histories that they've experienced with some degree of abuse and with lots of abuse. It has certainly contributed to this here situation. So, in order to honor, my patients and populations, I just want to draw attention to the historical and current contemporary struggles that Indigenous people face, and some of the relationship to incarceration therein. Um, so let's start, and I'd like to start by exploring some ethical challenges with providing MAID in correctional healthcare settings. I ran into a colleague and they said to me, "Oh, I didn't know that you were an expert in medical assistance in dying in correctional settings." And I said that I am not an expert. And I thought this is a point that I need to make very clear at the outset of this presentation. I just happen to be a clinician working in a correctional setting who has encountered several patients who experienced MAID assessment due to some ongoing issues that they encountered. And as someone who's interested in ethics and the healthcare of individuals who are incarcerated, that sparked my attention. There was some urgency initially, particularly when I was looking at the mental health track of people, and MAID in Canada. Some deep concerns related to that, and we'll explore that kind of as we conclude this here presentation. So here is my information. My name's Stuart. I'm over in the Faculty of Nursing most times, over in ECA. Every once in a while, I end up in one of the prisons. I love doing that work. I love seeing patients, and I love taking on, some of the more challenging elements of healthcare in those settings. I have no financial disclosures. My joke always is, if you'd like to change that, please contact me after the presentation. So here are things that I thought we would chat about is, how MAID ended up being pertinent or a pertinent issue to contemplate in correctional healthcare, followed by some of the problems of medical assistance in dying in correctional and forensic settings, and then ethics and future directions to consider and possible ways forward as a society and nation we continue on offering MAID as a service in healthcare environments. So, this is where essentially MAID began. And remember, I said I'm not an expert. This is me just kind of, very high level overview. So the nuance that is often connected with this is absent very intentionally, because I'm not going to spend time here. But these are the Karen and Quinlan cases of years and years ago, where in the final hours or days of their lives, experiencing terrible pain, suffering, mostly related to cancer. Palliative approaches, medications just weren't working to alleviate the pain or the dyspnea or the suffering. And the question was, is it moral? Is it right to to end a person's life in that stage. And, in Canada and in relationship to the Charter of Rights and Freedoms and legal decisions and battles, the answer came to, yes, there are situations where medical professionals, nurse practitioners, physicians can, help a person end their lives within a strict criteria. Um, you know, and I think, those criteria were reasonably strict up front. And then, as the legal landscape continued to evolve, the criteria began to erode. So, initially the model was seemingly fairly simple, right? End stage for foreseeable death, objective suffering, often, very observable. People would often enter into a room and say, "Oh gosh, it's terrible the suffering that this individual, unfortunately, there needs to be something that could be done to help this individual as they die." So patients genuinely wanted to end their suffering. Their suffering was just incompatible with living, and they wanted to have that ability to end the suffering. And like I said, the question at that time was, is assisting a person to end their life in these circumstances morally and socially acceptable? And the society in Canada responded, and amended some laws and statutes and implemented regulations to allow this case to unfold. So now, you know, uh, MAID is a way to alleviate intense and irremediable suffering caused by medical conditions, except for mental illness that was paused in consenting individuals at a time of their choosing. So, some of the the measures in my read of in my understanding of the program around having a foreseeable, death, reasonably foreseeable in months or weeks. Some of that has been loosened. Ideas around what constitutes suffering, the objective measurability of suffering. It really was more of a contextual, nuanced, subjective understanding of suffering and how an individual experience suffering as it relates to a particular disease process. And then there's this discussion around what are the social obligations and responsibilities in terms of alleviating that suffering. So things like improving access to healthcare. So with the mental illness, accessing mental health programs, accessing maybe medications that would be, unavailable or unaffordable, providing additional community supports. So there is, kind of another angle that we're looking at here. So, um, some of the expanded models, some of the questions were, how close to death does someone need to be for MAID? And then some of the additional nuances in this evaluation component to determine whether someone's quote eligible or uneligible for MAID is really focusing on this. What are some of the modifiable factors by society that influence an individual's decision making around MAID? So, can this MAID be quantified? They are still capable in a capacity perspective to freely choose, kind of the time and place and potentially even mode of their death. So this kind of played out a little bit in correctional care, and I'm not going to divulge the precise cases. There's some factors here that have been um, altered just to protect the identity of the individual or individuals who've moved through this process. But this was an individual who one of the individuals who was under my care, and um, they had a chronically painful condition, similar to rheumatoid arthritis. Let's say that would be kind of an analogous condition. Death was not foreseeable, but the person was in chronic pain, was in a lot of pain. They had poor control in community due to various social factors, including homelessness, inability to access health care, substance use disorder, other competing demands, being on the run from police, evading police, to evade capture and whatnot. and in doing so, was not able to receive some of the earlier treatments for disease-modifying anti-rheumatic drugs, let's say. So the disease progressed fairly rapidly to a point where it's irreversible, and the person is known to have will have pain and will have pain the rest of their life. This time around, they will experience a provincial sentence. Legal disposition was a little bit unknown, but there was an anticipated sentence of around 18 months. We did consult with rheumatology and with the pain clinic, and the pain was optimally managed from those perspectives. However, the patient was requesting increased doses of narcotics, some other medications that just weren't available in that setting, some other health services that weren't available, free of charge in that setting or in the community setting. They reported that the pain was unrelenting despite all of our best efforts. And as a consequence of this, they requested that they be assessed for medical assistance in dying, saying that their medical condition was so severe that they would meet that criteria under the suffering and irremediable facts. So here, um, some of the current issues that we would encounter in corrections, is this distrust to trust relationship. And this is mutual between the patient and myself. The patient doesn't necessarily come to my clinic trusting me up front. And they're suspicious of my existence in a prison. They aren't sure who I'm working for, if I'm really allegiant to their personal health concerns, or I have a underlying motive perhaps. And this is often a greater distrust of health systems and social systems and society in general. For a variety of different issues. And equally, there's distrust between healthcare professionals and their patients. Um, we are often skeptical of some of the reports, particularly reports of pain. Some of the issues around manipulation. These are well-known factors that kind of shape the interplay in the therapeutic relationship in corrections that we just naturally need to acknowledge. The other issue that we often need to recognize is the majority of our patients who are incarcerated are uh, characteristically have at least traits of cluster B personality traits, and most often kind of that antisocial personality type or borderline personality type. And I don't say this in a pejorative way. I know that historically personality disorders could sometimes be used as pejorative labels to, abandon a person for care, just to place them in a bad, mad type category. But I say it here just to highlight that some of the ways that the people exist in prison is oriented towards injuring, society and the people in it. And that's one of the reasons why often, people find themselves incarcerated is they can't necessarily follow the rules of society, or they've offended society, harmed other people through various, illegal activities. And this was the case with my patient. There are certainly perceptual issues. So I did some research in pain, and that's in prison. So where I looked at understanding how people experience pain during periods of incarceration. And pain actually can be worsened. Pain intensity, perceived pain, and overall pain experiences are shaped by prison settings and by the social structures in prisons, particularly delineated through, kind of hypermasculine, toxic masculinity, distrust, fear of injury, concerns around being, very powerful and physically strong and capable, um, fear of becoming injured, fear of people finding out that they have pain and thusly weaker. Some of that fear and anxiety certainly can influence how pain is experienced in those settings. So I just want to highlight there. That's a separate presentation, but I just want to say that yeah, there's actual things in prisons that can influence, pain that could be at play here with this patient who has a pain experience that's interpreted as suffering, and during their period of incarceration. Legal issues, certainly there's the ethical and legal principle of equivalence of care. So, people who are incarcerated, we have an obligation to provide excellent care to this population of individuals, and that is because as a mature nation, we do follow the conventions that are set forth for us in our local, national, and international codes. Um, and objectively is the right thing to do as healthcare providers. That's our commitment. It's also the right thing to do from a legal perspective and in order to protect society. So if we uh, refuse or treat people improperly during periods of incarceration, including withholding medical care or using a medicine as a form of torture, the people who are incarcerated could advance issues in terms of, habeas corpus applications and asked to be released from prison. Under a violation of the Charter and rights and freedoms, and this happens from time to time. Habeas corpus applications are not routinely granted. They're often dismissed as most often frivolous, but there are situations where, yeah, um, there have been found to be significant violations of the Charter of Rights and Freedoms that are unnecessary, that are beyond just merely detaining an individual and restricting their rights of movement, that could essentially not absolve a person of their crimes, but the remedy would be to you'd have the person released from jail. So, if we release this person from jail or don't act properly from a healthcare perspective, and these people are released from jail, there are potential threats that people who are violent are returning into society and able to then continue on, harming society or injuring society in different ways. The other element here that I just want to highlight in prisons is there's historical prison issues that pain and punishment often went hand in hand, and the retributive form of justice is based on atonement and suffering. So the crime, the punishment must fit the crime, an eye for an eye. So there's an equivalence that of suffering that must be endured by an individual in order to atone for the offense they've made into society. That form of punishment exists in various areas of the world. In the U.S., capital punishment would be one example of that. In other areas where pain is inflicted onto the body through stoning, through other forms of torture still exist. In most civilized societies, most justice scholars would agree that that is not the way that a civilized society should act or treat people in this way. That torturing is wrong, and objectively wrong as a value statement. Um, and then, of course, there's the pains of imprisonment. So this is often conflated with pain and imprisonment. So when I was doing my PhD, I had to do a lit search about pain and incarceration and imprisonment. And what I was looking for was how much pain do people have who are incarcerated? Like nociceptive pain. I broke my ankle pain, and how is it treated? And a lot of the literature, especially in the humanities, really focused on kind of this idea of Gordon Sykes' pain and imprisonment. So the pains of imprisonment are unavoidable, and they really focus around deprivations of being deprived, societal interactions with other people, being deprived heterosexual relationships. This was from the 1950s. That was seen as important in kind of heteronormative perspective and whatnot. Again, this here is often linked to suffering. And when we're talking about unremediable suffering, this can be at play. So, things that we need to pay attention to are things like, can is the suffering caused by imprisonment, or worsened by imprisonment? Is that a remediable factor? Is that a remediable factor? Is that something that we need to pay attention to? Um, when we are assessing MAID. And how will our MAID assessors know that, right? Um, as someone who works in corrections, I could assess MAID. I could be involved with that. I'm in Alberta, so I would. Thankfully, there's a service that will help do that for us. And I think having an arm's length evaluation, especially of people who are incarcerated, is probably useful. But how will that be interpreted? If someone is suffering is worsened by incarceration, um, or that this and there is a pain associated with that, and we know that pain intensity could be worsened because of incarceration. Could a person's be removed? Could the recommendation be that a person be removed or released from prison as a way to prevent MAID from occurring? These are are uh, are theoretical, hypothetical, maybe not seen as viable or feasible at this moment, but they're the way that policy tends to unfold. They're important things to consider. So MAID in prison ethics and future directions. I think a future model of MAID, and this is when we're looking at the mental health track. There's seemingly a further expansion, and that's been placed on hold. And yeah, I'll admit, I've really not paid a whole lot of attention. I mean, MAID was always in the background, but the idea of implementing MAID in corrections just didn't enter into my forebrain at the initial onset. Initially, if someone was in a state of palliation and required medical assistance in dying, at the end of life, of course, I would refer them to our MAID services, and if they qualified, we could get a temporary absence. We could have them released from jail, or if there was a danger, the officers could go with them and sit at their bedside, in a hospital or in a hospice situation, and even be there when the person experiences, undertakes MAID. I mean, that's physically possible. And as things progress, some of my attention is being refocused here a little bit. People are suffering, kind of the model is people are suffering and want to end their life. Death is not foreseeable. So, people are suffering from often mental illness. For many years as a mental health care professional, we've been trying to not have people end their lives. And in fact, we would often say that people who were suicidal and wanted to end their lives were incapable of making sound decisions. And that was often the basis for forming them, making them an involuntary patient, having them conveyed to hospital, confining the individual and causing the individual to undertake treatment under a Mental Health Act. There's a lot of subjectivity that is at play here. What does suffering look like? How is suffering enacted, right? And how does the social condition impacting the subjectivity of the suffering influence the MAID decision making itself? So the idea that free will exists and that MAID decisions are straightforward and unattached to any other factor is not likely in these more nuanced situations. So autonomous decision making is unlikely, is what I'm saying. And then the broader question I would pose is how can the values and dignity of society and people living within it be maintained within this future model or proposed model of care, whatever that of MAID, whatever that potentially looks like. Okay, and this is certainly something that I'm not going to answer today, and there's probably a million other questions that spur from this and viewpoints and whatnot. Um, but relational ethics, I would say would be potentially one of these here factors. But before we get in there, let me just you know move a little bit forward. Sorry, I'm just going to back up here. Let me just help you understand some of the context again that we're potentially looking at. So is imprisonment a modifiable factor, right? How does being incarcerated influence one's ability to choose, freely choose, that should be freely choose medical assistance in dying? So, in a incarcerate setting, a lot of decisions are influenced by the environmental structure or even, the schedule of incarceration. So, I have, routinely people who as decisions to engage in healthcare, to have a surgery that has been planned, to have the blood tests that they wanted, to have a medication assessment or a medical condition reviewed or assessed in clinic, decline those those opportunities because that was the day where canteen orders were being placed or canteen was being delivered. And if they didn't get their canteen on that day, they may be hungry, experience hunger. They may not be able to pay off debts, so there may be some threats to safety. So some of the decisions that are made are 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 influenced by some of the most mundane elements of incarceration, right? So if someone could decide not to have a surgery that they need and want because of the canteen schedule and owing a bag of chips to someone down the hall, um, that there's possibility that issues and decision making around MAID could similarly be influenced, right? Antisocial personality disorders. Um, there's an element of those type of people who have those types of traits where there's an intentional harm towards society and others. Um, and, we do see this not only in prisons, but elsewhere in society. I'm thinking about, an individual who was in experienced some form of disability, and the disease state was advancing to a point where the only real option for them that was being offered by the health services was, to have them go into a nursing home. And this individual found that to be an unreasonable option, something they didn't want to undertake. They wanted to have increased home care, 24-hour services, lots of money invested. And that was something that, that the health system and society in that jurisdiction just was unable to provide. So, the person made a decision to end their life. And after they end their life, it revealed that they they actually didn't want to end their life, and that they wanted to continue to live, but they wanted to live in the way that they described by having an increased support at home, increased funding, and the like. And that there's an element of lacrimal validity there, where certainly individuals in this situation, they're in a desperate situation. We feel pity, we feel compassion for people in these situations, and some of the things that they're asking for are not necessarily unreasonable, but they may be unattainable for a variety of reasons. But the approach then of saying, hey, I got the state to kill me, but I'm using this to to demonstrate how I didn't really want to die as a mechanism to influence public policy. That is very manipulative. And I don't want to uh, you know, injure someone's character who's died. Most of us don't. So it's an unpopular opinion. But I use that as an example to illustrate, some of the lengths that people will go potentially to injure society, and achieve their own end goals. So, I had a patient uh, you know, who basically wanted nicotine, and knew that if they were in a hospital psychiatric setting, that they would have access to nicotine and smoking, and engaged in some egregious forms of self-harm as a way to have them transferred from a prison to the area where they wanted to, so that they could smoke cigarettes. And the facility, would say, well, this is behavioral. There's nothing psychiatrically wrong with this individual. It's manipulative behaviors to achieve the aims that they set out to achieve. The lengths of harms were quite severe, where we're removing body parts. Uterus was removed, stabbed, requiring a hysterectomy. Colon segments were removed. I've had other people remove, testes, for example. So, I don't provide these as examples to just horrify people, but just to highlight that, there's two elements here, is that we tend to see very egregious forms of self-harm behaviors in these settings, and the lengths that people will go potentially to harm the fabric of society, including ending their lives, is not necessarily unreasonable. And that's a kind of a forensic, perverse way. There's other, more generous possibilities, but I don't have time to review those. Personality disorders and psychopaths. So, a person who's a psychopath, who has a sociopath or psychopathic tendencies, who just doesn't have an empathetic response to other people, who every time they are in community, um, acts violently towards other people, habitually murders other people, or experiences paraphilic disorders. They have a chronic tendency to molest children and find themselves recurrently in jail. Would this fit with a suffering pattern? Or is a pedophile suffering from pedophilia, from a paraphilic disorder, manifested or marked by recurrent recidivism, where they could claim or request medical assistance in dying? And as a state, as a society, are we prepared to end the lives of people who are engaged in these disorders? And then as a society, are we mature enough? Are we able or capable enough to place aside sometimes our objective want for people who are incarcerated and engage in some of the most horrific acts, violence and abuse, to be injured and potentially even die. So that would be getting into kind of this idea of the punishment imperative, where as a society, sometimes our minds say, wow, that person, that's just an abhorrent individual, and the things they've done, they shouldn't be permitted to live. Or, if something happened to them in jail, I wouldn't be unhappy, right? And certainly, if you're the victim of a crime, you could have those emotions, those feelings, and those are quite natural. But we can't allow society's apathy towards medical assistance in dying, um, in these kind of situations, to degrade into a situation where we're passively permitting the state-sanctioned killing of people who are incarcerated, right? Um, a case of relational ethics, I think, when I look at this subjective element of involved here in some of the more nuanced cases and in prison, I do see some promise that relational ethics in the Dosseter Burgum kind of tradition can offer. The relational ethics, uh, as many of you would know, the original theory really uh, tests uh, the the premise that decision making is autonomous, and that people freely choose um, uh, decisions and care, healthcare decisions or decisions in their life freely and unconnected from other realities or circumstances. And it places that at the center and said, no, decisions are influenced by all kinds of different things, and that we need to understand those different things as a way to move forward in a reasonable way, right? The goal is in relational ethics to find a solution that is fitting, that it's often described as harmonious to all parties. Um, and uh, and the parties here would need to be the patient, of course, but also needs to be the justice system and the health system. There are some complexities around, the justice system that we do need to pay attention to. The kind of covert killing of people and medical assistance in dying, counseling, or encouraging people to take up MAID as an option, certainly continues to offend our laws. Uh, um, you know, the overly, quote, generous assessments for medical assistance in dying, um, and how that relates in a forensic capacity. So you can't be generous or in assessing for MAID, you need to follow the rules because a generous assessment, if you're faking it, you're committing a federal crime. Um, what does worry me a little bit is that there may not be a right fitting answer, right? There may not be um, an answer that is harmonious to all parties. Um, the best answer, the best we possibly could do, is Wendy Austin once pointed out in a similar forensic context, is that we can undertake the least worst thing to do. I would envision that the least worst thing to do would probably default be not offering MAID or declining MAID services. Um, One of the reasons I would say this is that relational ethics finds fitting responses. It's a subjective ethics rooted in a phenomenological philosophy or a phenomenological study. It's the empirical results of phenomenological study. So there's a tentativeness in those decisions, with an understanding that as time passes, as knowledge evolves, as people develop a greater understanding of the situation, or as as the situation changes, that the outcome of the decision can too change, right? The other concern that I have is around ethical relativism. And, this is, I think, the day after relational ethics, mutual respect book was published, and some of those earlier research studies were published. I think that, that this concern about ethical relativism appeared. And the concern is that we could use relational ethics or the framework for relational ethics in a malicious way to explain away poor behavior or bad behavior. Um, and, when situated with this punitive imperative, which, by the way, is often an unconscious bias among members of society, including ourselves, um, there may be a risk for decisions to be influenced or framed using kind of a relativistic approach. So in a way, what I'm saying is as we move forward, this may be one area of further research to better understand medical assistance in dying, and how that could potentially unfold in correctional or forensic or even mental health settings. So I rarely do this, but I ended perfectly on time. Um, I went through a lot. There's a lot more that I could go through, but I want to stop there and just give the opportunity for individuals to pose questions, should there be any. Um,